Hyperemesis gravidarum. So this is a condition that usually affects a majority of women in pregnancy. As the term says, hyperemesis is increased emesis, vomiting, in gravid when you are pregnant. So we're going to do an introduction, the incidence, the risk factors, pathogenesis, investigations, management, and prevention. So hyperemesis gravidarum, we've said, is high increased emesis, vomiting in pregnancy. So it's usually protracted nausea, vomiting in pregnancy. So it has a triad of more than 5% pregnancy or pre-pregnancy weight loss. The patient dehydrates and there is derangement of electrolytes. So when we have a milder form of the same, it's called morning sickness. So what's hyperemesis gravidarum? It's a protracted nausea and vomiting with a triad of more than 5% pre-pregnancy weight loss. If you were 55 kilos before pregnancy, then you lose 5% of the same. You are dehydrated and you have an derangement of electrolytes. So it usually has shown a fall in incidence, in occurrence because of hospital practice, better application of family planning, and there is early visits to the antenatal clinic. The causes are usually many, and the theory surrounding the same is usually limited to the first trimester. Most common in the first pregnancy, with a tendency to recur again in subsequent pregnancies. It has a familial history. It is more prevalent in hidacidiform mole and multiple pregnancy. It's common in unplanned pregnancies. That's interesting. So the theories surrounding it, we have hormonal causes, excess chorionic or nodotropic hormone. There is high serum levels of estrogen, and there is high levels of progesterone that causes relaxation of cardiac sphincter and simultaneous retention of gastric fluids. The others like thyroxine, prolactin, leptin, and adrenocortical hormones. There is other cause, there is a theory, psychological, dietary deficiencies such as vitamin B12, B1, and proteins. There is allergic and immunologic basis. There is decreased gastric motility. Then we can have a cycle vomiting, carbohydrate starvation, ketosis, and vomiting. So usually they present with ketoacidosis, and the reason is because of loss of carbohydrates in vomiting. The clinical cause, the onset is usually 5 to 6 weeks of gestation. It peaks at around week 9, resolves by 16 to 20 weeks of gestation. Symptoms may continue until the third trimester in 15 to 20% of women. 80% of cases, symptoms persist throughout the day. Risk factors, Western countries are more common than Africa and Asia. The multiple gestation, the superstarters, the genetics, motion sickness, heartburn, molar pregnancies, female fetuses is more common than male. And then, of course, there is some reason here, an interesting topic about alcohol use and cigarette smoking, protective in Hyperemesis Gravidarum. The common signs and symptoms: persistent nausea and vomiting, pregnancies in early periods, there's loss of weight, we've said a triad, and then there is ketosis due to loss of carbohydrates and dehydration. The scoring scale for Hyperemesis Gravidarum, when someone scores around less than 6, 7 to 24, and 13 to 15, it's called PUQE 24 score. So 3 questions. How long have you felt nauseated? How long? Or have you vomited? How many times have you head retching or dry heaves without bringing up anything? So, not at all, less than 1 hour, 2 to 3 hours, 4 to 6 hours, more than 6 hours. So it's not at all, less than 1 hour, 2 to 3, 4 to 5, more 4 to 6, more than 6 hours. So have you vomited more than 7 hours? More than 7 times? You score 5. So less than 1 hour, vomited 5 to 6 times, scores 4. 3 to 4 hours, has just vomited 3 times, given 3. 4 to 6 hours, has just vomited 1 to 2 times, the score is 2. And this is how you score, and then you give it a range. So if the total is less than 6, is mild. Moderate, 7 to 12. Severe is 13 to 15. So how can you investigate it? Initial evaluation, you do examination, you do weight, and then you do vital signs. Laboratory for those with persistent nausea and vomiting, urinalysis, you do urea electrolytes and creatinine. There is evidence of hypokalemia. When you do complete blood count, there is increased hematocrit. Blood urea nitrogen, there is increase due to hypovolemia. You do liver function tests, mildly elevated in 50% of the cases. Transaminases, serum lipases and amylase, blood gas analysis, metabolic alkalosis or acidosis, thyroid function test, there is increased T4. Hypomagnesemia and hypocalcemia. Pelvic ultrasound can help to confirm the viability of the fetus and exclude multiple pregnancy or molar disease. That's very important. However, some mothers can come to the hospital with all they seem pregnant. They have vomited more than 3 times, and the score is the PUQE score, 24 score, is around 7 to 12, but they don't have hyperemesis gravidarum. So the cause might be PUD, peptic ulcer disease, cholecystitis, gastroenteritis. They might be having hepatitis. They might be having pancreatitis, or they might be having a UTI, pyelonephritis. Now, in the treatment goals, what are you aiming? Determine the disease severity. Check how severe the nausea and the vomiting is. Correct hypovolemia. Reduce symptoms. Prevent seriousness and complications of vomiting. minimize the fetal effects of maternal disease. So when the mother comes with the nausea alone, what do? You adjust the diet. Advise them to eat small quantities of meals frequently to avoid hunger and full stomach. Determine and try to eat foods they tolerate best. There is evidence that ginger containing foods decreases nausea. Fluids, let them consume at least 30 minutes before or after solid food. They minimize the effect of full stomach. Most prefer aromatic liquids, carbonated, lemon, mint. Avoid triggers, the diet that can trigger nausea, the changes and environmental triggers, the noise, the stuffy rooms, heat, flickering lights. Then pharmacotherapy for nausea alone, you can use pyridoxine, vitamin B6, 10 to 25 milligrams per oral. You can give QID 6 hourly or 8 hourly. You can give doxylamine succinate and pyridoxine together. So you can adjunctive therapy, acupuncture. You can give physiotherapy. Or if the patient is having vomiting without hypovolemia, you can add an antihistamine. You can also do dopamine as a second line. So the first line, vomiting without hypovolemia, antihistamine. Second line, dopamine, serotonin antagonist. Adjunct therapy, acid-reducing agents. You can do histamine 2 receptor blockers, for example, ranitidine. You can do PPIs, esomeprazole. So vomiting with hypovolemia, usually patients will present with lassitude, postural dizziness, thirst, tachycardia. There is decreased urine output. Admit the patient, and when the vomiting has persisted and is abnormal electrolyte balances, give IV fluids. The fluids that you need to give the initial fluid is up to 2 liters IV, Ringer's lactate, infused over 3 to 5 hours. Normal saline isotonic based. Infuse rate 100 ml per hour. You can give 5% dextrose after initial replacement of fluid therapy. Avoid use of dextrose in initial replacement fluid. It can cause Wernicke's encephalopathy when given in thiamine deficient state. If hypokalemic, give 20 to 8 milliequivalent of potassium 2 to 4 times per day. Saline, dextrose you can give in it. The vitamin replenish the low levels of vitamins, especially thiamine. B1 IV you need to give. Diet, nutritionist consultation. IV ondansetron can be given as well. So if vitamin B6, 100 milligrams, QID, doxylamine, you can add. So we've said promethazine, you can add it when it's so severe. When there is no dehydration, you just give metoclopramide. There is dehydration, Ringer's lactate. Then add 5% if necessary. Refractory cases are common. Then, if there is that, admit and give treatment as we've discussed earlier. The special population, for example, diabetics, you educate. and treat and avoid hypoglycemia. The outcome usually is good when treated and managed well. But compared to normal women without Hyperemesis gravidarum, rate of miscarriage is high. Rate of congenital malformation is not also high. Miscarriage and malformation, is not high. So the complications, the sequelae, is usually wernicke encephalopathy, bleeding diathesis from vitamin K deficiency, malnutrition, esophageal tears, osmotic demyelination syndrome, hepatic insufficiency, venous thrombosis, acute tubular necrosis. The need can recur. For patients, 15 to 20%. How to prevent it early? Daily multivitamin with folic acid. Decreased congenital anomalies with all those iron. Thank you. Till the next time we meet.